So thank you for the introduction. One of the things that I want to mention as a disclosure is that my talk is going to be from a perspective of a hepatologist and not an endocrinologist. So I want to begin by showing you the global prevalence of fatty liver disease along with diabetes. And what's apparent from this is that while the global prevalence of fatty liver disease is about 1 in 4 or 1 in 3 people, in diabetics, that number is considerably higher. In some countries, 70, 80% of diabetics will have fatty liver disease. And more importantly, the prevalence of MASH will be about 30 to 40%, and about 15%, 10 to 15% may have advanced fibrosis. So diabetes is common, MASLD is common, and the interaction between the two leads to much, much higher prevalence of more aggressive disease and more advanced disease. So this just shows how the two interact. And in patients who have MASLD but don't yet have diabetes, the likelihood of progressing to diabetes is considerably higher, sometimes 2, 3, 4, and even 500-600% higher in some studies. Now, the reverse is also true. In people who have fatty liver disease and they get their fatty liver disease under better control, the likelihood of developing diabetes over time also goes back to being normal. So what this data shows is the close relationship that MASLD and diabetes share. And the importance of making sure that we're treating it adequately, because that is going to improve clinical outcomes in these patients. I've showed a version of this slide, but I want to add on to this. So as we all know that insulin resistance is a driver of multiple things, and depending on where it is, it does different things. But in adipose tissue, it causes more fatty acids to be released. These are then taken up by the liver and stored as fat. It also causes increase in how much fat the liver itself makes. But these can be augmented further by the types of food that we eat. And again, the synergistic effect of all of this is that there's more fat that is being deposited in the liver. And not only does this affect the liver, but it also affects different organs. So the heart becomes involved, the kidneys become involved, patients get pancreatic beta cell failure. So people who had subclinical insulin resistance will become overt diabetics, and patients who were medication managed diabetics will become insulin dependent diabetics. And then they also increase the risk of cancer, different colon cancer, breast cancer, gynecological cancer, all the cancers that have been shown to be much, much higher in patients with fatty liver disease. And this is what leads to a clinical outcome. It's the relationship between insulin resistance, as Dr. Sanyal had mentioned previously, with liver, heart, kidney, pancreas, and then cancer risk. So instead of thinking that we're going to take a patient who has diabetes and treat their diabetes, get their hemoglobin A1C under control, and call it a day, I think it's insufficient. Because their risk is multi-organ, I think the better strategy is to see, can we use medications that addresses all of those risk factors? So at the end of the day, we don't protect their liver, or we don't protect their diabetes, but they die of a heart attack, they die of a cancer, or so on. So the approach to managing these patients is not a single disease or single organ, but rather the entire patient. So with that conceptual framework in mind, I'm going to show some of the more commonly used medications that have activity both for diabetes, but also liver disease, and how does it affect the overall metabolic health. So this is data with pioglitazone, and as we all know, and this has been shown in multiple studies, that use of pioglitazone can improve liver disease. It can improve NASH. It improves every single parameter associated with liver histology, with the exception of fibrosis. And it's fairly well tolerated. And more importantly, pioglitazone also helps heart disease. These are older data when the medication was still relatively new, and it shows that patients who have underlying heart disease, use of pioglitazone reduces the risk of atherosclerotic event, whether it's a stroke, whether it's a myocardial infarction, and it's a significant, and it improves survival in these patients. But there are side effects of pioglitazone. So pioglitazone, at least in the United States, is not used as routinely because one of the key side effects with pioglitazone is weight gain. And if pioglitazone is stopped, the weight gain does not necessarily go away. It causes edema. Patients don't like edema, so they complain about it, and as a result, we tend to stop pioglitazone. And then patients with fatty liver disease, they have a significantly higher prevalence of heart failure, so diastolic dysfunction. So in patients with underlying fatty liver disease, with underlying subclinical diastolic dysfunction, if they get started on pioglitazone, there is a potential that they can have a heart failure exacerbation. So these are some of the factors that have lessened the enthusiasm for use of this medication in clinical practice in the US. The next sort of the big thing that's all over the news is GLP-1 receptor agonist. And this is looking at data with semaglutide in patients with MASH. And we know that semaglutide tends to improve histology and different parameters associated with it, both in multiple doses. But this is a study at New Journal of Medicine that was recently published that showed that improvement in NASH histology with semaglutide, particularly the higher dose, and the phase 3 clinical trial is currently underway looking at higher dose semaglutide for management. But semaglutide or GLP-1 receptor agonists cause substantial weight loss. So considerably higher than patients who are in placebo. And this weight loss tends to happen fairly early on after medicine is initiated. And even if medicine is stopped, the weight doesn't always go back to where they're starting from. So there is some net benefit of this medication, even if it's stopped. And while patients are on this medicine, it tends to improve other risk factors. The blood pressure is better. The inflammatory markers are better. Obviously, the hemoglobin A1C is better. So there is a net metabolic benefit of using GLP-1 receptor agonists. So it tends to actually improve that metabolic risk profile considerably more so. Now, it does have side effects, particularly the GI side effect, and we don't understand it well. What is the sustainability of these? Do they stick around for a lot longer when the medication is stopped? So we don't yet know. So there are some unknowns with this. But it improves renal disease, it improves cardiac disease, improves blood pressure, vascular function, it causes weight loss. So there are a lot of benefits of GLP-1 receptor agonist. SGLT2 inhibitors are also sort of the second agent that has shown promise in both diabetes and treatment of liver disease. And as you can, so the data with histology with SGLT2 inhibitors is not quite there yet, but using non-invasive biomarkers, SGLT2 inhibitors such as empagliflozin tends to improve liver fat. And there is some data that it may also improve elastography as well. But again, these are data from non-invasive tests, and we don't know how it improves histology itself. So the jury's still out, but if you had to use medications for co-treatment of patients with diabetes, this is one of the things that I would consider. Now, one of the things that Dr. Sanyal was mentioning is how insulin resistant drives what type of fuel source we use. So in a fasted state, we tend to use fat. That's where all the action, that's where all the weight loss happens, is when people are not eating, because that's when the body is forced to use fat. And in patients with NASH, what happens is even if they're fasting, they can't use fat. They have to make more glucose or they have to eat. So what happens in SGLT2 inhibitors is in the fasting state, they tend to use more fat and they're less reliant on glucose. So SGLT2 inhibitors fixes this metabolic flexibility. So it has a net positive metabolic effect. It also reduces cardiovascular disease risk, both from heart failure, but also atherogenic events. It also improves renal function. So it reduces the likelihood that someone's going to go into need dialysis, need a transplant, or die from renal factors. So again, when we look at the entire picture, what we see is SGLT2 inhibitors have a wide metabolic benefit in patients who have diabetes and potentially fatty liver disease. It does increase risk of fractures. It does cause more infections, particularly urinary tract infections, but it also has significant metabolic benefits. And then this is saroglitazar, which most of you, all of you, I'm sure, are familiar with. So it does improve NASH histology considerably. And the phase 3 trial is currently underway, but it also has a huge effect on metabolic risk profiling. One of the key factors that drive clinical outcomes, cardiovascular outcomes in patients with NASH is this small dense LDL. So LDL comes in different sizes. The big ones tend not to be as much of a problem. The small ones tend to be more of a problem. And the reason for that is the small ones are able to, they have lower affinity for LDL receptor. So once they get secreted, once they're in circulation, they don't get taken back up. So they spend more time in circulation and they are able to get through the subendothelial layers in blood vessels. So they deposit more, they elicit more inflammation, oxidation, and eventually plaque rupture. So small dense LDL are a key factor that lead to cardiovascular events or atherosclerotic events in patients with NASH. And that's one of the things that saroglitazar does nicely. It actually specifically reduces the small dense LDL much better than other medications, including statin therapy. But no talk would be complete without talking about metabolic effects of diet. And this is a study that looks at that diet has a huge impact. So patients who are put on a Mediterranean diet have a significant reduction in the liver fat. And it also reduces the likelihood that they will have clinical cardiovascular disease. They will go on to develop diabetes, peripheral arterial disease, atrial fibrillation. So Mediterranean diet works. And the more adherent the patients are, the greater the degree of reduction in these relative risk is. So diet plays a key role in it. And this diet doesn't cost any money. It's cheap. As long as the patient gets right counseling, they understand the risk, it can be implemented widely. So just to summarize, there's a strong clinical correlation between MASLD and diabetes. While there's no approved drug therapy for MASLD in the United States, in India there is, saroglitazar. Several diabetes medications have liver benefit. There's pleiotropic metabolic benefits of diabetes medication that address key causes of morbidity and mortality in patients with MASLD. And then lifestyle modifications should be an integral component of any medical therapy in co-management of MASLD and diabetes. Thank you.